On my Peloton. So
Oh,
All right. Well, good afternoon. Jamie, how are you?
good. I feel like I'm in a different spot. We traded places today, didn't we?
Yes, absolutely. You deserve it. Uh, Dr. Shader is here with today. Dr. Shader, how are things today?
today's beautiful
Yeah.
day here in Iowa. Yes.
Excellent. I am so excited about today. I think it's going to be a great conversation, but it's going to be a duel between an endocrinologist and a nephrologist. So, by the way, folks, while you're joining, please type in your name, where you are from. That'd be good. And those who might be listening later, please know that we'll answer your questions and comments regardless. So please chime in and keep joining in. So we think alike on some ways, but we are different in many ways. Like I'm a Diet Coke guy, and he is. Oh, there we go. He's a Diet Pepsi guy. So we have our differences, and some of those we'll show today. But here's Sharon from Iowa. So welcome to our group here,
And I am excited because you guys, I mean, through this last couple of weeks when prepping, you guys are goofballs and I love it. And so I really do think that we are going to have fun here today. So I'm looking forward to it and sitting back and watching the show.
Excellent. I think it's time, so let's get going. All right. Well, welcome everyone, and today is a great day to be here. Did you know that 1 out of 5 people with diabetes will develop kidney disease?
I knew
Out of
that.
5.
I knew
You
that. I
All
knew
right.
that. Okay.
Excellent.
Yeah. All right. Good.
I'll tell you a better one or a worse one, which is that diabetes is the #1 cause of people going on dialysis. And
I
that's
knew
a
that
shame.
too.
Excellent. So there we are. We're on the same page now.
Okay.
So what about today? We will talk about why diabetes increases the risk for kidney disease, how to prevent kidney disease, and then how to monitor your kidney health. And to do this, let me just introduce the team. First of all, I'm Dr. B, Dr. Bhargava, trying to change diabetes for the last 25 years or more. And then Jamie Pitlick, who runs this show, and all know her, very passionate about diabetes. And then our rock star for today, Dr. Shader. He is a nephrologist or a kidney doctor. He has been in Des Moines practicing for the last 41 years. And apart from practicing, he also teaches a lot into medical education, also into golfing. Amazing artwork. His wine cellar is mind-blowing. I have about 0.1% of that cellar. So man of many hobbies. And I thank you for being here.
That's why I like Diet Pepsi, because I'm a super taster. Now, about 10% of people in the world are super tasters.
I see.
And I'm either blessed with being a super taster, or I'm cursed with being a super taster. So there's certain foods that I can't eat or drink. Coffee, for one, much too bitter, much too strong for me. Can't stand it. And I think that the Diet Pepsi is just more to my super taster taste than your will be.
Yes,
okay.
Of course. There you go. Meanwhile, Casey, hello, and Rose and Kathy from Ankeny. So thank you all for joining us today. All right. So Jamie, it's all yours.
Yeah, I'm excited to get going. We did get some questions from the audience pre-submitted. And I don't have times to explicitly outright answer them because you guys actually picked things that we're naturally going to talk about. So some of the questions were, what are some of the things that a diabetic can do to help prevent kidney disease? We are absolutely going to cover that today in this talk. What are the symptoms of kidney disease and what should I be looking out for? So we'll make sure to cover that. And then the other question was, guys, does this pertain to a specific type of diabetes? Is it type 1 versus type 2, or is it all types of diabetes? So I want to make sure we cover all of those points at some point during the talk, but I think we absolutely will.
One particular kind of diabetes, I'll tell you, and that's the uncontrolled diabetes. Controlled diabetes is usually a cause of nothing. So when we think of, and it's relevant to both type 1, type 2, with some nuances, but in general, it's more about controlled versus uncontrolled diabetes. So that's one piece.
And clearly both type 1 and type 2 diabetics can develop diabetic kidney disease. So that's clear. So what we're going to be talking about is applicable to both type 1 and type 2 diabetes.
Yeah. And I echo everything. And so especially that common saying, Dr. B, I think you and I have said it over and over, uncontrolled diabetes is going to be the cause of all of these things. But controlled diabetes is essentially the cause of nothing, but a good life. The other announcements for today are the Community Builder Award. This is our last show this month. And so we get to actually do the Community Builder Award, and we'll announce that at the end of the session today. And the other fun game that we have going for you guys is Today I Learned. So throughout this session, we want you guys to let us know what you're learning. So to let me know what you're learning, you're going to type in the chat, TIL, Today I Learned, and then whatever you learned. For example, today I learned Dr. B likes Diet Coke. Today I learned Dr. Shader is a super taster. So those are some of the things that I learned that I would type in. So we'll tally those up, and then the person who's learning the most, interacting with us, will get another little prize at the end of the session. So we want it to make it fun. We want to make it interacting, and we want to make you guys learn. So let us know what you're learning.
Let's start learning. Yeah.
To get us started, I do have a poll, like we start off most our shows. How much do you know about diabetic kidney disease? Let us know. A, never heard of it. B, I've heard of it. C, you've heard of it, but you know a little bit more. And D, I've got it, and I know a lot about it. Let us know. That'll help us figure out how much to add to what we're talking about. So we've got some answers flooding in right now. We've got Casey and Connie telling us they know a little bit. They've heard about it and know some about it. Rose knows a little bit more. So this will help
everybody to a C by the end of today, I can tell you.
Yeah.
That's the goal today.
Excellent. And another goal is so that in future they never have D.
Yeah, that's right. We're gonna try and eliminate D and go to C.
Okay. Very good.
Okay, I'll bring up our next slide, which kind of will get us into talking about the actual thing. But I believe, Dr. B, you have a question before we get started on that.
And the question is, you'll have to now remind me, remember in the setup?
Yeah. So
I do have a question. I have a lot of questions. Yeah.
So tell us about your guys' opinions. At the beginning, you guys said that diabetes was the leading cause of end-stage kidney disease, right? Or
That's
leading cause of dialysis.
Yeah, that's true.
Is that changing anytime soon?
I would like to hear your opinion on this.
Well, I think there are two different factors going in different directions. So in one direction, we have better control and better recognition and better treatment of diabetes, which is going to reduce the incidence of diabetic kidney disease. But on the opposite hand, we have an increasing number of individuals who are developing diabetes, especially type 2 diabetes. So my overall thought is it's probably stable or increasing.
Yeah, and that's kind of unfortunate. Really, this is a burden that can be reduced or eliminated. But I think we won't get there for several decades. A lot must change for diabetic nephropathy or kidney disease to go away.
Okay, that was the big, question to debate to get us started. But why don't we start going into what do the kidneys do for our bodies, and then what is diabetes kidney disease?
Okay.
I'll let you, Dr. Shader, enthrall the audience with your presence.
Well, I always say I always love a cartoon that I have in my office. It's a surgeon who's at the operating room table, and he says to his assistant, he said, "The kidney, that's a swimming pool-shaped organ, isn't it?" And so what do the kidneys do? Well, the kidneys really have a number of different roles. They're probably one of the smartest organs in the body. I always tell the cardiologist the heart is just dumb. It just pumps blood. It doesn't do a whole lot else. But the kidneys are really responsible for the excretion of waste products. So the body generates a tremendous amount of waste products through normal metabolism, and the kidney is responsible for the excretion of waste products. And we usually talk about measuring the waste products, and the blood test that's used to measure the waste products is often called the BUN or the serum creatinine. The kidney also is very important in regulating the body's fluids. So if you drink a lot of that water today, you're going to make a lot of urine today. And that's one of the roles of the kidney. The kidney can conserve water and conserve fluids, or it can excrete fluids. So it maintains the body's fluid balance. And it also maintains the body's chemistries. It's sort of the master chemist for the body. So it regulates the sodium level, the potassium level, the level of bicarbonate in the blood, the level of calcium, the level of phosphorus, the level of magnesium. So all of these important blood chemistry elements are regulated by the kidneys. And then the last function of the kidney, it's actually yeah. You had a question?
I'm an endocrinologist. Tell me more about this.
No, so this is actually, I'm an endocrinologist too.
Yes.
Because the kidney actually has an endocrine function in that it makes essential for some hormones. And two of the most prominent hormones that we talk about, one is erythropoietin, which is a hormone that goes to the bone marrow for the production of red blood cells. And the second is that the kidney is the organ that makes the active form of vitamin D. So you're out in the sun, you generate vitamin D2 or D3, but in order to get the active form of the vitamin, you need the kidneys to be intact.
Makes sense. Oh, that's great. So bottom line, kidney is extremely important.
Very important, very important.
Smart organ.
So guys, we already have people learning. We have 3 people that have learned something already. At least they acknowledged that they learned something.
That is great. That's the best news I've had today, personally. Yeah. Okay.
Yeah. So check, our jobs are done. Somebody learned something.
I can go home now. I'll see you. Oh, no.
So, that's what the kidneys do. But what about diabetic kidney disease? And how do you know if it's present or not?
Yeah, so that was one of the questions that you had. And unfortunately, one of the earliest signs of diabetic kidney disease before you develop any sort of clinical symptoms is usually some protein or some abnormalities in the urine that, unless your doctor is testing for it, you probably wouldn't know about. So before you start seeing any change in any laboratory values, such as the BUN or the creatinine that I mentioned, the earliest change in diabetic kidney disease is the presence of microscopic amounts of protein in the urine.
And I'll add something here, Dr. Shader. So symptoms-wise, these are silent killers. Diabetes is silent for the longest time. Diabetic kidney disease is silent for the longest time. To have symptoms is very late. So it's so important to get checked. So what would be some symptoms? Let's say people ignored and now they have advanced kidney damage. So, what symptoms might they have? So
some of the symptoms that people get with advanced kidney disease, with a kidney function that's less than 15% of normal, would include fluid retention. So the presence of edema, that would be an indication that the kidneys aren't working. An increase in blood pressure, that would be generated by the kidneys. That would also be an indication. And then for far advanced kidney disease, you get a decrease in appetite, you get mental issues, you get itching, you get a lot of other clinical symptoms that by themselves are not specific for their kidneys, because they could be caused by lots of other things, but are clinical manifestations of very advanced kidney disease.
Yeah. So bottom line, don't wait for symptoms. Get
Absolutely.
screened, and Dr. Shader will talk
and that's
about
why, and that's why screening is so important, in order to try and ascertain if someone is in the early stages of developing diabetic kidney disease. And once that, or even before that happens, to bring about intervention to try and prevent it. And that's what we're going to be talking about today.
Excellent. So, Jamie, there's a question I'd like to take from Noreen. What do you do about the side effects of many meds and combo insulins? Keep taking or stop? I would assume that this is in the context of kidney disease. I'll answer it that way. So as kidneys are responsible for processing a lot of medications, including insulin, when people get more advanced kidney disease, they may need lesser medications, lesser dose of insulin. Metformin, vitamin M, our favorite medication for patients with diabetes, that the dose has to be reduced if your renal function goes down, and has to be stopped once you get to stage 4 kidney disease as well. So
Yeah, I would agree with that, especially the issue about metformin, because the metabolites of metformin can build up in the body and have significant clinical consequence if people continue to take it with advanced chronic kidney disease.
So you guys mentioned, a little bit about things that that they can do to help prevent diabetic kidney disease. So I just wanted to ask the audience and have them brainstorm, what are some of the things that they think they can do to prevent diabetic kidney disease? And then we're going to start talking about some of that as well.
So folks, chime in. What do you think you can do to prevent kidney disease? And then I'll let
We already
Dr.
gave them a
Shader-
little bit of a hint. A very strong hint you gave them already for one of the things that you can do.
Yes, absolutely. All right.
Casey saying drinking water, potentially.
Yeah, absolutely.
Rose says limit salt.
Absolutely.
Hydrate, eat well. Vicky, again, another salt or sodium. Let's see.
No, you said the magic word where the little birdie falls comes down though about diabetic control. Did they? No one said. Okay, all right, good.
And Kathy's got one. Good blood sugar control. So I think I'll let you guys take it from there soon. But Suba does have a question that I think we could answer. I think you guys and talked about it a little bit already, but is the urine albumin the earliest indication of a kidney problem?
I think there's a slide Dr. Shader has, which really talks about this in a minute. So if we can hold, and then he'll answer through that. Is that okay?
Yeah, but basically, yes, that is true. In a one-word answer, yes.
Yes.
Okay.
All right.
Yeah. So I think some people have hinted on, what they think are ways to prevent kidney disease. From two experts, I've got two experts with me. Yes, I called you both experts.
Okay.
What is the most important risk factor for our patients to pay attention to prevent diabetic kidney disease?
Well, I think I'm very glucocentric. I am all about a diabetes doctor, right? So I'm all into sugars. In my mind, I think, Dr. Shader, I don't think it's what you are going to say. I think it's what I'm going to say.
How do you know what I'm going to say?
Well,
Can you read my mind, or what's the deal?
No.
All right.
So I think blood sugar control is extremely important for preventing kidney disease. But in your mind, what's the number one thing?
Well, in just a minute, we're going to talk about modifiable and non-modifiable risk factors. But it's not a question of either or, because it's not like, am I going to control my blood sugar, or am I going to control my blood pressure?
There is.
So yeah, I know. Okay. So actually, it's not like you're going to pick one or the other that you're going to do. You're obviously going to do both of them. So I personally think that probably blood pressure control is going to be the really. If you had to pick one, I would pick blood pressure control. I know you've already told us what you think.
No, I wish I could disagree, but blood pressure is so important for preventing kidney disease. But I like what you said. It's both. There's no choice. You got to control both. If you don't want kidney disease, your blood pressure and your sugars. So I'll let you take over. I know you have a lot of things to teach us today, so let's have you JB, let's get him to talk a little bit about the risk factors.
All right, so here again are, these are, I divided risk factors for diabetic kidney disease into two different categories. One are things that are not modifiable. Those include older age. I can't modify my age. Even with plastic surgery, I can't modify my age. A race, males are more likely to develop, sex, males are more likely to develop diabetic kidney disease than females. Race is very, very important. So if you are African American, or if you are Native American, or if you are Hispanic, or if you're an Asian or Pacific Islander, your overall risk, given everything being the same, is significantly higher for developing diabetic kidney disease than if you're Caucasian. And then lastly, if you have a family history of diabetic kidney disease, if you have a relative who's developed diabetic kidney disease, you're also at higher risk. Now, none of these things we can really change, but there are certain modifiable risk factors. So again, and I listed this first, hyperglycemia or diabetic control as a modifiable risk factor, blood pressure control as a modifiable risk factor, obesity as a modifiable risk factor, taking nephrotoxins, so things that drugs or chemicals that could harm your kidneys is a modifiable risk factor.
Dr. Shidder, what are some of those? What kind of things would people want to avoid?
Yeah, so some of those include some of the non-steroidal anti-inflammatory medications, you know, the drugs that we take for, or some individuals take for arthritis, but also
ibuprofen,
Aleve, Advil, you know, the whole list
but
of them.
the Tylenol.
Tylenol is okay, yes.
Okay.
But then there also are drugs that we administer in the hospital for good reason that can potentially be nephrotoxic as well. Certain antibiotics, for instance. So those are all potential nephrotoxins that should be avoided in individuals who are at high risk or who have diabetic kidney disease. Cigarette smoking is probably the worst thing that you can do. I don't know if it's the worst thing that you can do for yourself, but it's right up there. And then other things, acute kidney injury, usually related to some sort of medical illness, and a very, very high protein diet may also have a deleterious effect on kidney function. So those are all the modifiable risk factors that I wanted to mention.
So there's kind of a really loaded slide. There's so much information in Pearls. Jamie, if you want to bring that back on. There's kind of a couple of things I want to make comments and then emphasize something. So in terms of race, I have a question for you. I've always felt Afro-Americans are the highest risk, but do you think the other categories are in the same risk? Or African-Americans are the highest?
I would actually think Native Americans are at the highest risk.
Okay,
so if you, I don't know if you're familiar with the Pima Indians,
Sure,
in New Mexico, but if you're a Pima Indian, I don't know if we have any Pima Indians out there, but if you're a Pima Indian, you virtually are guaranteed to develop diabetes. But clearly African Americans, Native Americans, Hispanic, probably Native Americans, then African Americans, then Hispanics, yeah.
The second thing I would say, family history of diabetic kidney disease really echoes home. So I'm just sharing more of a personal thing. My father was on peritoneal dialysis for 5 years before he passed away. So it was hypertension related. And it's really painful to see them go through this. So one of the most important messages I could make for our audience today is, guys, this is serious business. You really do want to prevent kidney disease. And the good news is there's a lot in your hand. All the stuff on the right side of the screen is in your hands. So think about that. One last question on this slide. You said high protein intake. Right?
Yes.
Or very high protein intake.
Very high protein intake.
A lot of people in this group, a lot of my patients go on a high protein, low carb diet. It does wonders for their sugars. I have my own opinion on that diet and how it plays with the body. So what is your opinion in general on an Atkins diet or any high protein diet for your patients?
I really don't think that it's a great idea. You know, Dr. Atkins died, but but I really don't think it's a great idea. It does work in terms of weight loss, but I mean, there are other ways to lose weight other than by, the Atkins high protein diet. Yeah.
Got it.
So we have some comments on the side that I do think that we should address, and some questions for you guys. Some of the answers I don't know if we'll have, but I want to bring up a couple of Noreen's. Noreen asked or said something about, I found a fluid retention, a salt tab that runners use help my body absorb the fluid. Have you guys heard of that? Or anything in regards to that?
I'm curious.
So when I was a little boy, this was a long time ago, and I remember this. And it was a day like last week when it was very, very hot, and I came in from the golf course, and they had this bowl of salt tablets there to try and rehydrate. That really probably doesn't have much of a role, because most people get enough sodium in their diet that they will maintain normal total body homeostasis with just dietary sodium. And rarely do individuals need any sort of supplemental salt, especially with our current American diet and with the way that foods are fortified with sodium.
Yep.
Fortified or adulterated. I'm not sure which term I'd rather like to use.
And about how much sodium do you recommend for somebody? General population with diabetes, with high blood pressure?
Yeah, there's a tribe in Venezuela that virtually has zero sodium in their diet. Their main diet is with plantains, which are these things that look like bananas but taste like potatoes.
Okay.
And they are perfectly healthy. So you really do not need a whole lot of sodium in your diet. I usually recommend a dietary sodium intake in the range of 2 to 3 grams per day. I think that's probably reasonable and certainly doable for most individuals.
Yeah, so how would we know 2 to 3 grams? That's a little hard, right? So just think about avoiding high salt foods. The thing that, look at the label C. I mean, I used to love this Mrs. T mix for the tomato juice mix. And that had
the one you put the vodka in?
Yes. That
okay, all right.
60% intake of your daily salt. So look at that piece. Anything that's processed is going to be more salt. Don't add table salt. So some of those things you can do to restrict salt in your diet.
Yeah, and by the way, Pepsi's higher in salt than is Coke. Coke is higher in potassium. Okay,
that's
all
why
right,
I like
Coke.
There we go.
I knew we would get back to that.
There's a great comment from, can you read some of the next comments, Jamie? I do want to make sure we answer those.
So, I mean, there's one comment from Vicky that I think I want to bring up. Love the bow tie.
Thank
you.
Another bow tie. That's the other thing.
Another comment from Noreen about Viagra. And so she heard on a doctor show that she learned that Viagra helps open veins in the legs. Is there any evidence that shows to work in the kidneys as well?
I don't know any. The bow tie is actually an easier question as to why I wear a bow tie. And the reason for that is that I often spill, and it's very difficult to spill on a bow tie. The other reason that I wear a bow tie is I did a lot of pediatrics, and the one things that kids love to grab is your tie, and it's very difficult to grab a bow tie. So those are the two reasons that I wear bow ties. But now going to the Viagra, yes, I mean, Viagra does have an effect on blood vessels, but again, there's no evidence that in terms of renal circulation, it has much of an effect. It is used in terms of a treatment for something called pulmonary hypertension, where you want to increase the blood flow through the lungs. But it also, there's a caution in terms of Viagra and taking nitrates at the same time as well, because it could potentially prevent the effect of nitrates in somebody who's having an anginal attack or a heart condition.
Yeah. Bottom line, it's not something indicated for helping with kidneys. All right, Jamie, next, what question
next question I have for you, it's actually a Today I Learned, and it's from Dennis, and I just want to ask, so does metformin, does it build up and cause a higher risk for kidney disease? I know we have to dose adjust it in kidney disease. It's a common misconception. And so metformin's metabolites, or the breakdown products of it, if we have low kidney function, they can cause problems in the body. But metformin itself is not nephrotoxic and does no damage to the kidneys.
Metformin does no damage to the kidneys. That's an absolute.
I would agree with you. I would agree with you. And in someone who has kidney dysfunction and they build up the metabolites of metformin, it can lead to something we call lactic acidosis, which can be a very severe problem. So that's why the dose needs to be modified and or discontinued at various levels of kidney function.
Dr. Bhargava, any other? I'm kind of going through.
Yeah, so the question that somebody said, hey, my nurse practitioner mentioned that protein is not an issue. I think, so it's the context of high protein in which situation. So my concern about high protein diet is it's not sustainable for life. So when people go on a high protein diet, I'm backing off their insulins. When they get off, then I'm increasing their insulin. It does work for weight and so forth. So on a diabetes, if you can do it the long term and in moderation, I'm okay with that. The impact on kidneys is another important one. In many stages, it won't matter. But once you start getting that early stages of nephropathy, you really have to be careful that you don't stress your kidneys with more protein. So if you have a balanced diet, I'm a bigger fan of that versus high protein diet. There are some downsides to it.
You notice I put the high protein diet last, and the evidence is not extremely strong for a high protein diet being a modifiable risk factor. But what we do know is that when you eat a high protein meal, what happens is you actually increase your kidney function. You do something called hyperfiltration, which is actually one of the things that leads to diabetic kidney disease, or is a pre-existing risk factor for developing diabetic kidney disease.
Two more comments. One's a comment from Vicky. And her comment, I think, is powerful. And she says it's to her friends here, and it's similar to what Dr. B says. It sounds like her husband was on dialysis for 7 years for kidney disease. So do make the change. Vicky, thank you so much for sharing. Next comment is from Carol Lee. It's a question. So can kidney disease be stopped from advancing or be cured? I think this leads to some things that we are going to be covering.
We'll talk about that.
Let's just talk about diabetic kidney disease. So the best thing is to prevent it. And we talked about ways to prevent it. And we'll talk more about ways to prevent it. Once you have developed diabetic kidney disease, what we do and what our goal is to try and prevent it from being progressive in nature. That is, for it to be getting worse. So this is a slide that talks about the natural history of diabetic kidney disease and illustrates that it is not a short-term problem. It is a problem which develops over 10, 15, or 20 years. It starts with what we call hyperfiltration, where the kidneys are actually working overtime, which in turn leads to damage to the kidneys, and clinically is usually manifested by microscopic rolls of amounts of albumin in the urine, followed by the development of hypertension and followed by the development of overt proteinuria, and then much later the development of abnormal kidney function, leading to chronic kidney disease, end-stage renal failure, and the need for either dialysis or transplantation. So this gives you an idea about the natural history, that this is really a long-term problem. And what our goal is to try and, one, prevent it, and two, if it does occur, to try and change the natural history and extend that time frame out 30 or 40 years to prevent it from being progressive in nature. And we do that by looking at the modifiable risk factors and treating those, as well as some pharmacological therapy that we know will change the natural history of diabetic kidney disease.
Yeah. And I think looking at it, and so you have some different medicines and some different things that you have in your toolbox. And there's been a lot of changes recently on that.
Yeah, this is very exciting time in the nephrology community. So in the year 2001, a number of things happened other than, hitting the World Trade Center. But it was the year that the first studies called the IDNT and the Renal trial came out that showed the use of drugs that block the renin-angiotensin system, but we call them angiotensin receptor blockers, or short for ARBs, can change the natural history of diabetic kidney disease. Now, fast forward 20 years later, 2001, we now have additional drugs that we know can change, all in addition to the angiotensin receptor blockers, the natural history of diabetic kidney disease, specifically the SGLT2 inhibitors.
Awesome. Yeah, and those, I mean, just to give you guys understanding, SGLT2 inhibitors, Farxiga, Jardiance, Invokana, and Stiglatro. Those would be the 4 on the market that we have available in the U.S.
And then, Dr. Shader, what is the class, the ACE inhibitor? Some names, drug names people can know that they should be on, ACE or ARBs. Can you mention some names?
So the ACE inhibitors include drugs like lisinopril, enalapril. They all end in pril, which is very easy to identify them. Captopril is another one. I'm blocking on the rest of them.
Oh, there's a lot.
It's stage fright, I think.
So pril is one class, and then the ARB class, the second
ARB class.
Sartans.
Are all sartans.
Pharmacist, okay? That's
I'm taking her show. So it's losartan or valsartan or candesartan.
So make sure, talk to your doctors about being on this class of medicine. We used to say every diabetic should be on that. The current wisdom is either you have high blood pressure, then you be on it, or you have protein in your urine, and then be on it. So if either of those things apply, you need to be on one of those classes. And Jamie, if you could send information afterwards on these 2 classes, plus the SGLT2, that might be good for people to know. And
I believe Kathy is asking, the effects of Zocor and lisinopril, I believe, on kidney disease. So here we're telling you, lisinopril will prevent the progression of diabetes kidney disease. Now, Zocor is a statin. It's simvastatin, so it is a cholesterol medicine. And so it's working in a completely different pathway. So working more on heart protection versus kidney protection.
Exactly. Heart and stroke protection. Yes.
Yeah. I think we're starting to come across the time where we normally wrap up. We've covered a lot. There are a few more questions. Doctor, yes.
I just wanted to say that also there's a bit of a bright horizon out there as well for additional drugs that may be coming. So one of those drugs is known as a mineralocorticoid receptor antagonist. The drug that is finerenone is the drug that was recently approved by the FDA and will certainly, or at least the board for the FDA, and will probably get FDA approval for the prevention of progression of diabetic kidney disease. And I know that you were one of the investigators in the Fidelio trial.
Yes, we have been very lucky to be part of many of these trials, and it's so hard to get a medication to market that impacts diabetic kidney disease. So it's exciting to see the Figaro Fidelio trials bringing up a medication, the SONAR.
So there's and then there's some on the horizon in addition to that. There's endothelin A antagonists. The SONAR trial, which we were actually also involved in, is another drug. It has not been approved, and there are a number of other drugs that are out there that have a potential for changing the natural history of diabetic kidney disease. Okay, I'll get off my soapbox.
So help is on the way. Help is on the way. But again, the most important thing is to not get there. And there's so much you can do about that. So I think, Jamie, you have a poll while you pull that up about screening and stuff. One of the things that we're talking about is the numbers do matter. We talked about the blood pressure control, blood sugar control. So one question somebody might ask me is what kind of A1C I should be looking at? It depends on a number of things, but it's either 7 or sometimes 6.5 is your A1C that you shoot for. Dr. Shader, question for you. Somebody has high blood pressure, what blood pressure number is good for them
Yeah.
to prevent kidney disease
So
progression?
there's debate about this too. So according to the ADA and the KDIGO, which is the nephrology symposium, the target blood pressure is 130 over 80 or less. The European Society of Hypertension actually has a target blood pressure of 140 over 90 or less. But the important thing is getting the blood pressure under control and having the patient have stable blood pressure, especially so that they're not symptomatic from having too low a blood pressure, because we really don't want to have people passing out. You know, it's just not good.
Yep. So it's not like you can keep driving these things. 140 over 90, I personally am uncomfortable with that goal. So I customize it 130 over 85, but I don't go 120. If somebody is in teens, I'm backing off on their blood pressure medicine. So lower is not always better. You reach a certain place, and that's where you want to be. You also don't want to shoot for a normal blood pressure or blood sugar number. There are too many risks with that. So it's a fine balance. Talk to your doctor. Jamie, you had some questions or thing you wanted to ask.
I've got questions. I do want to touch on screening. I know we promised that to Suba earlier. So for our audience, I've got this question. How often should you be screened for diabetic kidney disease? This is if you don't have disease. So every month, every 6 months, every year, every 2 years. How often should you be looking for this? We'll talk through the answer, but before we start talking through the answer, we'll let you guys answers. Also, Dr. B, Dennis Olson is asking about side effects of metformin and whether or not you should be on it lifelong once you get put on it.
So in my mind, metformin is a beginning to end medication. There should be a strong reason to stop. And usually kidney function going down is the reason. Side effects are mostly stomach side effects, bad taste of mouth, nausea, indigestion. And that's why we start slowly and titrate up. It's such a wonderful medication that I try all sorts of different types. The regular metformin, the extended release, the later version like Fortamet or Glumetza, as I said, they have lesser side effects. I try all sorts of things to make metformin work. And there should be a strong reason to stop it in patients with type 2.
Vince is asking, and this is probably a really long answer, but I think you are the right one to shorten it up. What is an alternative to metformin if you're taken off of it?
So I used to think that metformin will never be replaced, but there's a class of medicine now that I think is a very strong contender. And if it was generic, I think in my books, it would replace. And that's the class Dr. Shader talked about, the SGLT2 inhibitors, those work in the kidneys. When you use them, sugars go in the urine, the calories go in the urine, the salt goes in the urine. It reduces your blood pressure, blood sugar, weight. It also reduces your risk of heart attacks and strokes. And as it turns out, it also reduces your risk of kidney disease. So I think that class of medicine, the Januvia, Farxiga, and so forth, those are the medications, Jardiance, Teclatro, those are the medications that I think are the top contenders now for taking metformin's position. And as soon as they become generic, they'll be my number one treatment for diabetes.
Yeah, that's the big issue is the cost.
Sure.
Yeah.
Back to people say, what's the
answers? Lots of answers. So we have yearly from Vicky. Another Vicky said she's never been screened. Casey said every 2 years. Suba and Connie said C, which is every year. Carla said yearly.
Sorry to cut you short, Jamie, with the interest of time. We are beyond, but you guys got it. Most of you got it. Every year you want to get screened for kidney disease. Do not wait for symptoms. So how do you get screened? Get a urine test done at your doctor's office. That's the key thing you want to do. There are some nuances too. It should be repeated and so forth. But the bottom line, get your urine test done once a year. Get your kidney test done once a year. That's all what I would say to keep it simple. There are some nuances that in type 1, you don't have to do it for a few years after diagnosis. But the simplicity is once a year, get a blood and urine test.
So I want to know, what are your guys' takeaways from today? We've covered so much. Highlights, I'm going to limit you to top two things that you want the audience to take away.
Diabetic kidney disease is unfortunately common, and it is hopefully preventable.
So from my side, control diabetes is a cause of nothing. So control your diabetes, control your blood pressure. And the other thing I would say is get screened. I see 2 or 3 people saying I've never been screened. That is not good. You got to talk to your doctor, get your test done. So put it down as one thing for your next doctor visit for sure. Jamie, what are your top 2s?
Okay, my top 2. Well, my top 1 actually is nothing medical at all. My top 1 is just amazed at you guys, the audience interacting with us today and all the TILs. I loved this session and watching what you guys learned and interacting with us. It has been one of my favorites. So that's kind of my big takeaway.
Excellent.
Excellent.
Well, let's
thank
bring
you.
it home, Jamie. I think you have a few things to say at the end, and then I'll sum it all up.
I want to know who the winner is.
There we
Yeah.
go.
Oh,
So
okay.
we have a community builder award for the slide says May, but we are in June. So community builder award for June this month is Tyler Crawford. So congrats. Thank you for being in our Facebook community and for trying to make and help us change diabetes in Iowa. So awesome job. And then the Today I Learned winner, let me see, I've got that in the chat. That is going to be Connie. Connie is our winner today. So thank you, Connie. All the comments, good job.
Connie, go Connie.
Excellent.
Yeah, so thank you guys. The interaction has been great. We are getting ready for our next session. We are trying to make these continue to improve the sessions and make them exciting and engaging. So we are changing the format just a little bit. We're going down to once a month. It'll be the last Wednesday of the month. So on July 28th, we're going to have another session called Making Mindful Menu Choices. So basically, how do we eat at a restaurant? We found that the average sit-down restaurant meal is over 1,000 calories, which is usually over half of what you should be eating in a day, considering that most people, it's an 1,800 calorie. So we are going to talk about how to make those mindful choices so that you don't eat all of those calories when you're going out for dinner. So be sure to join us. In addition, we're going to be going live a little bit more often next month, but there'll be shorter videos and shorter interactions. So we'll do the big one like this, but then be on the lookout for us going live in some smaller sessions at different times. So we'll start doing some evening times and on different days. So we're excited to expand in what we're doing.
Great. Well, everyone, thank you so much for joining. And Dr. Shader, thank you once again for making the time to
It's a
come and
pleasure.
talk to our
It's a
team here. We are just very, very appreciative. Guys, let's keep working on changing diabetes together in Iowa. Have a great day.